Okay, hello everyone. My name is James Callahan from the Michael Garron Hospital IPAC team. I want to thank you for joining us today and welcome you to another LTC CIP group lecture. Today we have my wonderful colleagues Victoria Serapion and Brigitte Pascual, who will be presenting the third lecture in our series, Identification of Infectious Diseases. Victoria holds an honors Bachelor of Science from the University of Toronto. She majored in human biology and health studies. She is currently employed as an infection control associate here at Michael Garron Hospital in Toronto, where she provides IPAC support to our withdrawal management services program, as well as a number of long-term care homes that we support through the IPAC hub. Brigitte comes to Michael Garron Hospital's IPAC team after 11 years at the bedside as a nurse in LTC, and our medical director recognized her talent for IPAC really quickly, and she joined MGH in 2021. Brigitte supports a community practice where she guides 10 long-term care homes to improve the delivery of IPAC programming for the residents. And with that, let's start the lecture. I'm pleased to hand over the presentation to Victoria and Brigitte.
Okay, I'm just going to share my screen now. Okay. Okay, thank you, James, for that introduction. So welcome back to the LTC CIP prep group. Today, Bridget and I will both be covering identification of infectious diseases. And just so you're aware, this section of the exam will contain 18 out of the 135 scored exam questions. So these are the objectives today. We will cover them over the next few slides. So our first category, our first topic is clinical signs, symptoms, and risk factors to identify possible infectious diseases. So this is the chain of infection, and many of us are familiar with this as it is a model that's widely used within infection prevention and control. And it's important that we understand the components of this model as it can help identify infections and any interventions that should be implemented. So to briefly overview and go over the components of this chain, we first have the infectious agent. This could be a bacteria or a virus. Next, we have the reservoir. This is where the microorganism will live and survive. Then we have the portal of exit. This could be how the microorganism leaves the reservoir, so through open wounds or through aerosols. And then the mode of transmission is how they get from the portal of exit through a portal of entry and into another susceptible host. So the mode of transmission could be contact, or it could be ingestion or inhalation. The portal of entry is the way in which a microorganism will enter another reservoir. And then the susceptible host is any person that may become infected with any microorganism. So as infection preventionists, our goal is to break this chain. And so it's important to implement IPAC interventions at any point of the chain, whether it's hand hygiene or PPE or cleaning and disinfection. So that brings me to my first question. Which of the following are considered common examples of portals of exit? Is it A, B, C, or D? And you can pause the slide here and I will go over the answer in the next slide. So the answer is B, respiratory tract, blood, and transplacental. So once again, it's important to know the portals of exit. So these are common portals of exit, which again are it is the way that an infectious agent will leave the reservoir. So age-associated changes are caused in conjunction with alterations in all major systems of our body. So some commonly reported health conditions include hypertension, arthritis, heart disease, cancer, and diabetes. And in 2003, CDC conducted a study and it concluded that roughly 80% of the elderly population live with at least one of these chronic diseases that I had just mentioned. So our body undergoes a process called immunosenescence, and this is essentially when our immune system dwindles as we age. So for example, the natural decrease in the number and availability of certain white blood cells reduces the body's ability to fight off infections that we often see in the elderly population. We should remember that immunosenescence is different from immunosuppressed in the sense that the immune system is not suppressed caused by a medication or a condition. It's just that our immune system doesn't have the same kick as it used to. So this is an image of the effect of immunosenescence on the immune response to vaccines. So you can see that someone with a healthy immune system will have adequate antibody response, but someone who has immunosenescence, they have decreased T cell activation and dysfunctional antibodies, so they have diminished antibody response. So in addition to the presence of chronic diseases or degenerative diseases mentioned above, other changes can also lead to risk factors for the host. Once again, think of the chain of infection, and these factors can increase the chance that the agent will complete the chain of infection. For example, thinner skin combined with poor hygiene practices could lead to increased breakage of the skin and create a portal of entry for pathogens. In the Venn diagram above, malnutrition and nutrition plays a part in one of those complicating risk factors as it could potentially create imbalances in the body. So malnutrition is the imbalance of nutrients in the body compared to actual physiological requirements. This could be due to reduced intake, absorption, or utilization of nutrients. And undernutrition is a specific type of malnutrition that occurs with a reduced intake of appropriate nutrients that can cause weight loss or an altered immune system. And this could be due to changes in the oral cavity, tooth loss, maybe they have a retainer or diminished saliva production, difficulty chewing and swallowing, so dysphagia, decreased taste sensation, and a loss of appetite, impaired cognition, depression, or medication side effects. And then your T cells, which are white blood cells that mature in your thymus gland, which is why they are called T cells, are highly influenced by nutrient uptake within their environment. So T cells will help with your adaptive immunity, and any changes in your overall nutritional status can result in altered T cell metabolism and their ability to respond adequately to these pathogens. And just so I can kind of paint a picture to show the importance of nutrition, reports have indicated that the prevalence of undernutrition is higher in long-term care facilities than in non-long-term care facilities, which occurs in as much as 30%, 37% of the population in these facilities. So as we age, we may face more complex health conditions, which could require increased use of medications and antimicrobials. And that being said, it's important to remember that antimicrobial use effectiveness diminishes over time and with use due to antimicrobial resistance. So this is why before taking a new antimicrobial, there are some considerations to make, such as renal and hepatic function, infection site, administration route, mode of excretion of the antimicrobial, potential toxicity of the agent, and allergy history. And this topic will be discussed in greater detail during the antimicrobial stewardship program session. This brings me to my next question. So, undernutrition is most heavily associated with impaired immune function, manifested by a decrease in cell-mediated immunity of which of the following? A, B, C, or D? So the answer is D, T cells. Once again, the primary cells of cell-mediated immunity are your T lymphocytes, also known as your T cells, which recognize and will destroy human infected cells with microorganisms. And this function is extremely important for the destruction and elimination of infectious microorganisms. The next topic will be diagnostic, radiologic, procedural, and laboratory reports. When you're analyzing these different reports, it's important to become familiar with them as it's helpful for infection diagnosis, assessing the stage of infection, and evaluating healthcare-associated infections as well. Nowadays, you'll see that many of the reports will detect for antigen and antibody reaction or response as opposed to waiting for a culture. And you can remember the difference between what the antibody looks like versus an antigen, because antibody ends in the letter Y, and you can see here that it is shaped as a Y. And then for antigen, you'll just remember that they stick off the virus or the bacteria. For these reports, there's basic principles to keep in mind. So QS, also known as quality systems, is a term defined in the Clinical Laboratory Improvement Amendments, which refers to all policies, procedures, and processes required to achieve quality and reliable testing in order to provide safe and effective care. So to meet the standard, we should have a laboratory personnel who is trained within the scope. We need quality assessment, and then we'll also need proficient testing programs. So within quality assessment, we have a process that begins with the pre-analytical state, which is, for example, a specimen collection or transport. This could be collecting the urine sample. Next, we have analytical, which is maybe equipment or reagents and interpretation of results. This could be the lab running the sample in the machine. And then this is followed up by post-analytical, so your reporting of the results, also known as maybe the nurse discussing the results with the physician. So these are more terms that we should get to know in order to be able to discuss the outcome of these results. So accuracy measures the ability for how close the result is obtained to the true value. And it's described through two terms, sensitivity and specificity. So sensitivity is the ability of a test to detect all true cases of the disease or the absence of false negative results. And specificity is the ability of a test to correctly identify a negative result when the disease is either absent or the absence of false positive results. So for example, rat tests are very specific to COVID, meaning that the flu won't create a positive rat test, but they are not super sensitive in the sense that sometimes you will have a COVID test, but the test might not be able to pick it up. So there's a chance that there will be questions on specificity and sensitivity on the exams. So here's some mnemonics that you can remember to help you with these terms. So for sensitivity, you can remember the word snout. So a test with high sensitivity, S, when negative, N, helps to rule out a disease, out. And then for specificity, you can remember the word spin. A test with high specificity value, SP, when positive, P, helps to rule a disease in. So it's important to note that without accuracy, a test could reproduce an incorrect value. So it's important to know these terms as well. And then two more terms that you should become familiar with include precision, which is how consistent the results are when a sample is tested repeatedly, and susceptibility, which is how successful an organism is able to be treated by a microbial, which will be discussed later within this session. Diagnostic testing is widely used for screening individuals with or without any signs of or symptoms of an infection. These tests have a higher sensitivity, but because of low specificity, they require confirmation from a positive screen. The diagnosis can then be made on the disease state or characteristic. And these tests are able to detect for the actual agent, also known as the antigen within the specimen. It can also look for immunological response or the antibodies, and it can also use nucleic acid hybridization to see if any agents are present. And to break down what nucleic acid hybridization is, it's a process that separates the DNA and it looks at a specific segment, then it puts it back together and it amplifies it to create billions of copies, and then it's able to study it in closer and greater detail. And an example of this is a polymerase chain reaction, and we do this technique to help with disease diagnosis, detection of pathogens, analyze any mutations, or genetic testing. These are common tests that you'll see in our long-term care facilities. For cultures, we have gram stains. We also have AFBs, and we have culture reports. And then for lab tests, we have NAATs, PCRs, white blood cells, basic urinalysis, antibody detection, antigen detection. And then for diagnostic imaging, we look at chest X-rays. So the Gram stain is a method of differentiating bacterial species into gram-positive and gram-negative bacteria. And it was first developed in 1884 by Hans Christian Gram, and it was designed to detect peptidoglycan. So whether or not the stain is positive, gram-positive or gram-negative, it's an early indication of what type of family the germ belongs to. And we'll further discuss Gram stains within the next few slides as well. And an acid-fast bacilli stain, also known as an AFB, is another differential stain. And this type of testing can be used for individuals with symptoms of active tuberculosis, as we know that it takes quite long to get a culture report. So if you're testing for Mycobacterium tuberculosis, the sputum should be collected 3 times at least 8 hours apart, with at least one of them being an early morning specimen. And what AFB essentially means, acid fast, will indicate that the bacilli will hold onto the stain, which is why you're able to see it. For culture reports come from a technique that is used to grow or to cultivate bacteria and yeast. From a culture, you can yield polymicrobial growth, which is more than one type of bacteria. Pure culture is a single bacterial strain cultivated in your culture, or no growth could just mean that there has been no bacteria recovered from the clinical specimen. And you may also see the terms quantified, semi-quantified, and non-quantitative on these labs. And quantified could just indicate, for example, 50,000 colony forming units are in this urine culture, or for semi-quantified, it could just say that there's heavy growth of group strep A, and non-quantitative could just mean positive or negative. So these are just terms that explain the significant level of growth on the culture. Antibodies, once again, are these Y-shaped proteins that attach to the antigen, and your immune system will call for these antibodies, also known as immunoglobulins, that are produced by your B cells, developed from your bone marrow. So this process is also known as humoral immunity, as it's when the antibodies facilitate the removal of the agent, and it will circulate through the blood, secretions, or lymphatic fluids in order to do so. And antibody detection is an indirect way of assessing host response, in the sense that it can be reported either qualitative or quantitatively. So positive or negative, if there's antibodies there or not, or it can be represented in titers, so volume of antibodies. However, antibody detection should be interpreted in consideration with the predictive value of the specific test that you're looking at. Antigens, on the other hand, are foreign substances that go into your body, and they are proteins that sit on the outside of a virus or a bacteria, and this causes the immune system to then produce immunoglobulins. So these tests differ from direct specimen examination in that they generally incorporate the use of immunologic or serologic procedures by examining your blood serum, and this method directly examines to see the presence of an infectious agent. An example of this could be a rapid strep test, or a strep throat. And if you've seen these tests, they are strips of film, and you take your cotton swab with the specimen on, and the sample goes onto the strip. And if there are group A strep antigens present, they will actually migrate to the film to form a visible line of antigens that are bound to labeled antibodies. And another example of this could be one that we are very, very familiar with, which is our rapid antigen testing, because we can also see here that it uses lateral flow. White blood cell count is a common test also in long-term care facilities, as it indicates different infections based on your age and other comorbidities. The two types of white blood cell tests include counting for the total number of white blood cells per 1 cubic millimeter of blood, and white blood cell differential count measure for each type of white blood cell count in the blood. So leukocytosis, for example, means lots of white blood cells, and this is indicative of a bacterial infection. We also use basic urinalysis to test general health, and it can be used for red blood cells, white blood cells, casts, crystals, bacteria, or yeast. The test will also analyze color and clarity, presence of protein, glucose levels, blood, and leukocyte esterase. And leukocyte esterase is basically a screening test that is used to detect a substance that suggests that there are white blood cells within your urine, and this might indicate that you have a urinary tract infection. Chest rays are also commonly used within long-term care facilities as a diagnostic imaging test, as it can possibly show any fractures or lung complications within the resident. And it's useful to detect TB as it can also present in a any non-specific issues or pneumonia. And you can see here that in a normal X-ray, you can see right through it. However, when someone has COVID-19 or lung cancer, you can see all these white spots, which could indicate that there is a problem within the chest X-ray. And although as IPs, you won't have to diagnose a resident using these, it's important for you to be able to understand to see if there are any issues or complications that you should be notified about. This is my next question. So which of the following is the best example of an age-associated change that contributes to the risk for infection? Is it A, B, C, or D? So the answer is C, decreased white blood cells. So this is an example of an age-associated change. We know that white blood cells help to fight off infections in the body, but as you get older, you have a diminished amount of white blood cells within your body, so you're not able to fight all these pathogens as you were before. The next section is specimen collection, transportation, handling, and storage. So the key concepts for this section includes the idea that the microbiology lab is an important partner in the practice for IPAC. As IPs, it's crucial to have a relationship with your lab because you're not testing the samples yourselves. You'll need to know, for example, the turnaround time, and the lab will just be another resource for the methods of specimen collection, as well as any information on the microbes that are being tested. And it should also be known that the presence of microbes does not necessarily indicate a presence of infection. For example, this is where your post-analytical understanding will come in. And then finally, antimicrobial susceptibility testing is performed in order to select appropriate treatment. So for specimen collection, when you're collecting these specimens, you'll want to ensure that you're using standard routine precautions such as hand hygiene and appropriate PPE. You're using the appropriate collection device, such as a specimen collection kit. You're using appropriate safety devices to minimize risk of accidental needle sticks, cuts, or punctures. And you'll want to use sterile equipment and an aseptic technique. And then when you're collecting, you want to make sure that the specimen is collected in a manner that minimizes or eliminates contamination from commensal flora. You'll want to collect the culture prior to administration of any antibiotics when possible. If you're collecting sputum, for example, you want to collect the specimen at an optimum time. And you want to ensure that you have an adequate volume of material, as inadequate amounts of specimen may yield false negative results. So there are several specimens that can be collected in long-term care facilities, which include blood, sputum, urine, stool, mucosal surfaces, and skin and wound. However, for cultures specifically in long-term care, the most common collected tests are urine, stools, and swabs. So for urine, it should be collected in a sterile container and can either be collected through catheterization, through in and out or indwelling devices, which will eventually contain bacteria, or it can be collected through a midstream or a clean catch. However, the urine could possibly become contaminated with fecal, vaginal, or urethral flora while doing the clean catch. And urine can also become colonized and grow bacteria without any symptoms. And it's also important to know that the recovery of 3 or more species generally indicates that the specimen has been contaminated through faulty collection or delay in transportation to the lab. For stool collection, it should be done so in a manner that prevents contamination from both urine and water, and approximately the size of a loony, or until fluid levels rise with the appropriate transport medium. And for Clostridium difficile, also known as C. diff, the stool should be type 6 or 7, and it should take the shape of the container. For MRSA, the recommended sites to swab are your anterior neres, your perianal area, skin, lesions, wounds, incisions, ulcers, and exit sites of indwelling devices. When you're collecting your MRSA swab, you should pre-moisten your swab with sterile normal saline. Use the same swab for both nostrils. Swab the anterior neres using a circular motion, ensuring contact with all mucous membranes, and using a separate swab to swab perianal or perineal areas. For VRE, the recommended sites to swab are stool or getting a rectal swab or from colostomy sites, as stool specimens are typically preferred because enterococci is found within the gut. When you're collecting these VR specimens, you'll want to use a rectal swab using a pre-moistened swab with a sterile saline and insert the swab a few millimeters into the rectum until there is visible stool on the swab. For a throat swab, this can be done for group A streptococcus, and you'll want to gently swab the mucosa behind the uvula and behind the and between the tonsils and put into appropriate transport media. And finally, for a wound swab, you'll want to clean the wound bed with saline to avoid contamination of the culture, and press and rotate the swab, but do not swab any exudate or pus. Nasopharyngeal swabs or NP swabs are used for diagnosing viral respiratory infections and pertussis. Ideally, your sample should be collected as early as possible after the onset of symptoms, and proper collection will ensure a good diagnosis. And of course, when your staff are taking these NP swabs, they should have gloves, face mask, face protection, so your mask, your goggles, as well as any other PPE that they might need. For transportation, all specimens must be promptly transported to the laboratory, preferably within 2 hours of collection, as any delays or exposure to temperature extremes might compromise the test results. Specimens should also be transported in a container designed to ensure survival of suspected agents with the respective medium required for the specimen. They should be clearly labeled, including specific information regarding the site of a collection. For example, a clean catch specimen should be specified, or indwelling urinary catheter, and the requisition must match the label on the sample. And it's important to identify the specific specimen source or specific site correctly, as it helps proper processing methods and culture media for the lab to select when processing the sample. And all of this is information to know because it's important for us to receive results on time and the correct results. And finally, for handling and storage, you should be familiar with what samples can and cannot be refrigerated. For example, spinal fluid, genital, eye, or internal ear specimens can't be refrigerated. So it's important to know this when you are moving samples to and from the lab. And this brings me to my next question. A dementia resident at a long-term care facility has severe abdominal pain and a urine culture is ordered. What should the nurse consider when collecting the specimen? So the answer is D. Specimen should be collected following aseptic technique and using sterile equipment. So specimens should be collected during the resident's acute phase of illness, and they should also be collected before the administration of antibiotics whenever possible. And now I will hand it over to Brigitte for basic microbiology.
Thank you, Victoria. This next section talks about basic microbiology. Microbiology is the study of organisms too small to be seen by the naked eye, and clinical microbiology encompasses the study of pathogens such as bacteria, viruses, fungi, and parasites that cause disease or infection in humans. Fundamental knowledge of microorganisms, their identification, significance, and basic lab techniques provide the infection preventionists with an understanding of pathogenic organisms. Next slide, please. Bacteria are free-living single-celled organisms that multiply through chromosomal replication and cellular division. They normally live benignly in and on the human body, and only a small fraction of the thousands of identified species are known to cause human disease. It is prokaryotic cell structure that does not have a nucleus, membranous nuclear envelope, or membrane-bound internal structure such as mitochondria. They are small, with most ranging from 0.2 to 2.0 micrometers in diameter and 2 to 8 micrometers in length, and have implications with many IP concerns such as mask rating and effectiveness, air filtration, and cleaning and sanitation. In long-term care, Gram stain is the commonly used criteria to classify bacteria, and it provides an early indication of what type the family this germ belongs to. Next slide, please. The cell wall may be described as gram-negative or gram-positive, and this is important for classification, detection, and mitigation efforts. What are the differences between gram-negative and gram-positive bacteria? Gram-negative cell wall contains only one or very few layers of peptidoglycan, and the crystal violet stain will wash and only display a pink or red color. Gram-negative cells possess an outer membrane that is composed of lipoproteins, lipopolysaccharides, and phospholipids. These outer membrane help some organisms evade phagocytosis and confers the properties of virulence of the endotoxins, and bacteria can use this membrane to selectively keep antibiotic drugs from entering. It is important to remember that gram-negative bacteria are more resistant to antibiotics, whereas gram-positive organisms, they have a thicker peptidoglycan layer. Think of a thick sponge, and will retain the crystal violet stain, which results in purple or blue color. As infection preventionists, knowing the difference between gram-positive and gram-negative is important with reference to interpreting lab results and understanding the bacteria common to long-term care facilities. Next slide, please. Shape and organization. There are many shapes and organization patterns among bacteria. Basic shapes include spherical coccus or cocci, rod-shaped bacillus or bacilli, and spiral. Within the long-term care environment, the most commonly encountered and important bacteria are your rods and cocci. Cocci tends to be round but may be irregularly shaped, and their organization may be described as being diplococci, streptococci, or staphylococci. Bacilli are mostly rod-shaped, although some are oval-shaped and may appear similar to cocci and be referred to as coccobacilli. Bacilli may be organized as single, streptobacillus or coccobacillus. Bacteria can also be organized in clusters, chains, or pairs. Next slide, please. These are the most common gram-negative bacteria in long-term care: Legionella, Pseudomonas species, Enterobacteriaceae family. And under this family, it is important to remember that E. coli may become resistant to beta-lactams, and Klebsiella species may become resistant to carbapenems. Campylobacter, Campylobacter species, Helicobacter pylori, Neisseria meningitidis, and Bordetella pertussis. Next slide, please. And here are the most common gram-positive bacteria in long-term care: Clostridium, Bacillus listeria, Enterococci. They appear in chains and pairs and may be encountered as vancomycin-resistant Enterococci. Staphylococci, they appear in clusters. And the way I would remember this is I would think of a staph photo because everyone is all clustered together. And Staphylococci may be encountered as methicillin-resistant Staphylococcus aureus. And Streptococci, they appear in chains. So the way I would remember this is strip, so strip as in chains. And they may be encountered as group A Streptococcus. Next slide, please. Flora are microbes that normally live in and on the body without causing infection or disease, and there are two types. Resident flora are always present on the skin and the body, whereas transient flora, they colonize the skin and mucosa temporarily without invading tissues. Because resident and transient floras are shed by the host with the secretion of body oils and mucus and the shedding of the outer layer of the dead skin cells, common commensals become a transmission concern when healthcare workers do not follow the hand hygiene practices. Flora that are commensal in a certain area of the body may be pathogenic in another area. For example, E. coli is a commensal in the GI tract, but is pathogenic and may lead to infection when found in the urinary tract. Next slide, please. Virus. Viruses are obligate intracellular parasites. Obligate meaning they require a living host cell to grow and reproduce. Intracellular parasites meaning they are dependent on the cell's synthetic and metabolic machinery. Infection caused by viruses may be acute or chronic. They may be recurrent and may elicit lifelong immunity. Viruses can be classified whether it contains RNA or DNA or the presence of an envelope. Envelope viruses has a lipid membrane surrounding the protein capsid, making them easy to kill, whereas non-envelope viruses have proteins covering around the viral genome, making them difficult to kill. Next slide, please. Fungi are the most common causes of infection in individuals with altered immune system. Immunocompromised people are at increased risk for fungal infections and are most often infected by Candida albicans. Yeasts and molds are most important to know in clinical settings, and consider aspergillus when you do construction or renovation. Next slide, please. Parasites, it is an organism that lives on or within another organism and obtain an advantage at the expense of a host. In long-term care facilities, parasites that commonly cause GI and skin infection are of importance, and common exposure routes include undercooked or contaminated food. Next slide, please. Principles of pathogenicity. Virulence is the measure of a microbe's ability to invade and create disease in a host. Infectivity, this is the ability of an agent to invade, survive in, and multiply in a host. Pathogenicity is the ability of a pathogen to cause disease. Duration of exposure is the length of time the person is exposed to the organism, and size of the inoculum is the number of organisms needed to cause disease. Next slide, please. Host response talks about the immune system or immune response of the host. The immune system provides two levels of defenses. It's your cellular or innate immunity and humoral or adaptive immunity. Innate or cellular immunity is the spontaneous and the first line of defense against pathogens and effectively wards off infections by keeping pathogens in check. It is non-specific, and the cellular immunity includes physical barriers such as your skin, chemical barriers, and cellular defenses such as your basophils, eosinophils, neutrophils, monocytes, and macrophages. Adaptive or humoral immunity are expressed by proteins which are known as your antibodies, which are found primarily in your bloodstream and secretory fluids, and their important job is to stop the current infection and generate immunologic memory. Adaptive immunity includes active and passive immunity. Active immunity results when there is an exposure to a disease organism that triggers the immune system to produce antibodies to that disease, and it can be acquired through natural immunity from exposure to the organism through infection or vaccine-induced immunity. And lastly, passive immunity results when a person is given antibodies to a disease rather than producing them through his or her own immune system. Next slide, please. The antibodies are produced by B lymphocytes and they are called immunoglobulins. There are 5 classes of immunoglobulins. IgG, it is late occurring immunoglobulin in an immune response and is the longest lived. IgM is the early immune recognition and response, first reacting immunoglobulin. IgA is effective in preventing viral infection of the respiratory tract and intestinal mucosa. IgD, it functions in later immune responses, and IgE is the principal allergy-inducing immunoglobulin. In IPAC, IgG and IgM are the most important antibodies and most commonly asked antibodies in the exam. The way I would remember is IgG. G stands for grandparent. It's old, chronic, longest lived. And IgM, M is for mom. And as we all know, mom is always the first one to respond when you're injured or you're sick. Next slide, please. So question, a resident has a new wound that is draining pus. The physician has ordered a wound gram stain and culture. You get a call from the microbiology lab that the resident is growing gram-positive cocci in clusters. Which of the following pathogens is it? Is it A, B, C, or D? Next slide, please, for the answer. So the answer is Staphylococcus aureus, as the other three choices are all gram-negative organisms. Next slide, please. So for this section, I will be talking about the epidemiologically significant organisms. I will go through some of the most common type of infections in long-term care facilities, and I will also talk about the most common pathogens that cause this infectious disease and how to manage them. Urinary tract infections, respiratory infections, skin and soft tissue infection and infestation, GI or gastrointestinal infections, and blood-borne viral illnesses. Next slide, please. Urinary tract infections. It is important to remember that the urinary tract is normally sterile. UTI or urinary tract infections are one of the most common infections in nursing homes, accounting for 20 to 30% of reported infections. Risk factors for developing bacteria or bacteria in the urine and the UTI include age-related physiological changes to the genitourinary tract, neurogenic bladder, and use of catheters to assist with urination. The two broad categories of UTI are symptomatic UTI and asymptomatic bacteremic UTI. Symptomatic UTI, it's a UTI with signs and symptoms of infection, along with a positive urine culture, whereas asymptomatic bacteremic UTI is the absence of signs and symptoms of UTI, but a resident has a blood and urine culture positive for at least one organism. And because of this, or because of asymptomatic bacteriuria, this can be a driver of inappropriate antibiotic use in long-term care facilities. Next slide, please. CAUTIs, or your catheter-associated urinary tract infection. This is a type of UTI where an indwelling urinary catheter, for example, your Foley catheters, inserted through the urethra has been in place for over 2 days, and the resident develops signs and symptoms of UTI. 5% of long-term care residents will have their voiding habits managed by chronic indwelling catheters, as this is one way to manage urinary incontinence in this population. And the use of indwelling catheters has increased the risk of CAUTI, bacteremia, and septic shock, resulting in decreased functionality and possible acute care hospitalization and mortality. Urethral catheter will become coated with biofilm and will become infected, give enough time. Here are the most common pathogens associated with CAUTIs. E. coli is the predominant gram-negative organism of the normal bowel flora, and thus is the most common organism isolated from UTIs. And the other pathogens that are associated with CAUTIs are your Candida species, Enterococcus, Pseudomonas, Klebsiella, Enterobacter, and Staphylococcus species. Next slide, please. Infection prevention strategies, urinary catheter should only be used for appropriate indications, and the table below outlines the appropriate and inappropriate use of urinary catheters. It is also important to remember that urinary catheter should be inserted using aseptic technique and using sterile supplies. Changing indwelling catheters or drainage bags at routine intervals is not recommended and should only be changed based on the clinical indications. For example, if a resident has an infection, obstruction, or when the closed system is compromised. When a CAUTI is strongly suspected, remove the old catheter before obtaining a lab specimen, and this is done to prevent the influence of possible presence of biofilm. Urine dipstick tests are convenient to rule out the presence of infection, but may promote inappropriate antibiotic use for asymptomatic residents. Next slide, please. Pneumonia is an inflammatory process of the lung parenchyma caused by a microbial agent, and Microbial agents reach the lung through microaspiration of oropharyngeal secretions. Long-term care facility acquired pneumonia is among the leading causes of mortality, morbidity, and transfers to acute care facilities. Hospitalizations may not be routinely necessary, but however, depending on the severity of the infection and the facility's ability to provide optimal care. Long-term care facility who do acquire pneumonia may be at greater risk for functional decline, delirium, and pressure injuries when hospitalized. Common pathogens for pneumonia are as follows: Streptococcus pneumoniae or pneumococcus, and this remains to be a leading infectious cause of serial illnesses, including pneumonia among older adults in the US, and it is a vaccine-preventable disease. And the most common viral causes are influenza, which is also vaccine-preventable, and respiratory syncytial virus, or RSV. Next slide, please. Influenza is a contagious viral respiratory disease which is spread from person to person through large particle respiratory droplets. Transmission is possible before symptom onset, and droplets travel for less than a meter. Incubation is 2 days average, ranging from 1 to 4 days. Influenza A viruses are the only influenza viruses known to cause flu pandemics and most serious illnesses. Annual influenza vaccination is the primary method for preventing influenza and its complications. Next slide, please. Pneumonia prevention. Healthcare-associated pneumonia is often considered as an event that could have been prevented if the quality of care had been optimal. Some of the principles for prevention are as follows: influenza and pneumococcal vaccinations, adherence to standard precautions to prevent person-to-person transmission of microbial agents, respiratory therapy equipment maintenance. CPAP, or continuous positive airway pressure, is the most commonly used device that residents use in long-term care facility. And the mask and CPAP device are intended for single resident use, as the mask and tubing are contaminated with microorganisms after every use. There should be cleaning and disinfecting schedule for the device components as per manufacturer's recommendation. And also the water in the humidifier should be changed due to risk of Pseudomonas aeruginosa growth. Prevention of oral and respiratory infections through oral care or oral decontamination, as residents in long-term care facilities may be at particular risk for microorganisms in their oral cavity due to decreased saliva production, medication, chronic disease and debility, and poor oral hygiene. Next slide, please. Scabies is caused by a parasitic mite. It causes pruritic lesion in the hands, webs of fingers, wrists, elbows, knees, feet, armpits, buttocks, and waist. The itching is related to the allergic reaction. Incubation is 4 to 6 weeks, but shorter if the resident is previously exposed. It is transmitted through direct contact with the infested skin and requires contact isolation for 24 hours after the start of effective therapy. Healthcare personal prophylaxis is indicated if evidence of infestation such as a pruritic cutaneous rash occurs. Norwegian scabies, also known as crusted scabies, is a severe form that generally occurs in the immunocompromised and may produce less itching. Next slide, please. Diarrheal illness. Assessing the cause of diarrhea in long-term care residents can be a challenge, as long-term care facility residents may experience GI changes for a number of reasons, and most changes are not an indication of infection. Your job as IPs, or infection preventionists, is to help determine what is the etiology of the GI symptoms. Are these symptoms of infectious or non-infectious etiology? Infectious etiology may be caused by viruses, bacteria, or parasites. And modes of transmissions are usually fecal-oral, foodborne, or person-to-person. Next slide, please. Clostridium difficile infection, or CDI. Clostridium difficile is a gram-positive spore-forming bacillus that produces 2 large toxins, A and B. These toxins cause diarrhea and colitis in susceptible patients whose normal colonic bacteria microbiota has been previously disrupted by prior antimicrobial treatment. Risk factors for acquiring CDI are antibiotics exposure, use of proton pump inhibitors, those who underwent a GI surgery, those residents who has inflammatory bowel disease, exposure to healthcare, chronic immunosuppression, and the age of over 65 years. Pseudomembranous colitis is a more severe form of CDI in which patients exhibit a colitis characterized by the presence of pseudomembranes on the colon surface. The colonic mucosa shows punctate to confluent yellow, white, or gray plaques that are readily visualized at endoscopy. The ability of this organism to produce spores enables C. difficile to survive for months in the environment of healthcare institutions, from which it is transferred, which is spread by transfer of spores directly from the contaminated environment to the patient or by transfer on the hands of healthcare personnel who fail to follow good hand hygiene practices. Next slide, please. So diagnosis, stool culture is the most sensitive test of stool available. However, it is generally considered the gold standard for CDI diagnostic testing because of its sensitivity, but the turnaround time of 7 days prevents it from being employed in the clinical setting. Nucleic acid amplification tests detect toxin genes of C. difficile in stool have been approved by the U.S. Food and Drug Administration. These assays have higher sensitivity and specificity and possess a shorter turnaround time of several hours. It is a rapid, sensitive, and specific method to diagnose CDI when applied to appropriate populations who meet the criteria for diarrhea. Disadvantages, though, of this test include cost. It's really costly, and the risk of false positive results in asymptomatic patients. Colon endoscopy is used to detect pseudomembranous colitis. Next slide, please. Infection prevention interventions, place resident in contact precautions, and contact precautions may be terminated after the resident is free of symptoms for 48 hours. Consistent cleaning and disinfection is important as C. difficile spores contaminate the environment and equipment used in caring for residents with CDI. So 1 to 10 dilution of sodium hypochlorite or other EPA-approved C. difficile sporicidal product for disinfection is appropriate, and antimicrobial stewardship or antimicrobial restriction of clindamycin and control of use of extended spectrum cephalosporins have been effective at reducing CDI rates in several outbreaks. Next slide, please. Here are the most common foodborne pathogens in long-term care. Norovirus is the most common cause of gastroenteritis in long-term care facility. However, for the purpose of the exam, you have to familiarize yourselves with some of the most common foodborne pathogens in long-term care facilities. Just want to take note that listeria is an important public health concern in the US, and it primarily affects older adults, pregnant women, and adults with weakened immune system. And a resident with listeriosis usually has fever and muscle aches and sometimes preceded by diarrhea or GI symptoms. The elderly or immunocompromised patients may develop bacteremia or meningitis. Salmonella, gastrointestinal infections are acquired from eating contaminated food, and it is also important to take note that antibiotic resistance is increasing along some salmonella bacteria, and salmonella may also be found in the feces of some animals, especially those with diarrhea. Reptiles and young birds are particularly likely to harbor salmonella even if they appear healthy. So long-term care facility residents who participate in pet therapy and or other animal visitation programs must perform thorough hand hygiene at the end of the activity. Next slide, please. Norovirus or Norwalk virus is the common cause of gastroenteritis in nursing homes and the leading cause of disease from contaminated food, which includes like leafy greens, fresh fruits, and shellfish. Norovirus can be spread either by direct person-to-person contact or by fecal contamination of food or water and aerosol formation after projectile vomiting. Residents can be infected by touching surfaces or objects contaminated with norovirus, having contact with residents who are infected. Norovirus is highly infectious, and a small inoculum, as few as 10 to 1,000 variants, is sufficient to cause infection. There is no immunization or medication to treat. Treatment is supportive. Next slide, please. Infection interventions. Prevention is based on standard precautions in food safety. Use contact precautions for diapered or incontinent persons for the duration of illness or to control institutional outbreaks. Use of facility-approved one-step disinfectant and proper cleaning, disinfection, and ensuring that there is a kill claim for specific microbial agents, and reporting to public health as required. Next slide, please. Viral hepatitis. Hepatitis is a blood-borne pathogen. There are 5 types of hepatitis: A, B, C, D, and E. Vaccination is available for hepatitis A and B. Transmission of hepatitis B and C to dependent diabetic residents to healthcare personnel may occur through improper use of or reuse of contaminated blood glucose testing equipment while not wearing gloves, or unsafe injection practices. Outbreaks of hepatitis B and C in long-term care facilities have been reported, and hepatitis B and hepatitis C outbreaks has also been reported in dialysis facilities. Next slide, please. Infection prevention interventions is, of course, safe injection practices, adherence to standard precautions, cleaning and disinfecting blood glucose meters between uses when equipment is shared. Hepatitis V vaccination for hemodialysis residents and those with renal disease that may result in dialysis. Hepatitis V or hepatitis C screening for hemodialysis residents. Hepatitis B serology interpretation will be discussed in detail during the occupational health session. Next slide, please. Multi-drug resistant organisms are defined as microorganisms, predominantly bacteria, that are resistant to one or more classes of antimicrobial agents. MDRO infections have clinical manifestations that are similar to infection caused by susceptible pathogens. However, options for treating patients with these infections are often extremely limited. They are common in skilled nursing facilities, contributing to substantial resident morbidity and mortality and increased healthcare costs. Next slide, please. Here are the most common MDROs: methicillin-resistant Staphylococcus aureus or MRSA, vancomycin-resistant enterococci VRE, extended spectrum beta-lactamase or ESBL, carbapenemase producing Enterobacteriaceae or carbapenem-resistant Enterobacteriaceae, and multi-drug resistant Mycobacterium tuberculosis. Next slide, please. Antimicrobial resistant is the ability to inhibit or kill the organism with clinically achievable antimicrobial concentrations. It may be natural or innate. For example, your Acinetobacter baumannii, it has an innate antimicrobial resistance ability. It can also be acquired through genetic change, through inadequate treatment, or overuse and misuse of antibiotic. Next slide, please. Antimicrobial agents are substances that inhibit or kill microbes. Most are administered by IV or oral routes. Antimicrobials that actively kill organisms may be bactericidal or fungicidal, and antimicrobials that only arrest the growth of organisms and assist the host immune system in clearing the infection are bacteriostatic or fungistatic. MIC or MIC is the minimum inhibitory concentration. It just means that the lowest concentration of the drug that still can inhibit microbial growth. Next slide, please. Antimicrobial susceptibility testing. It determines appropriate antibiotic therapy, and one method commonly used is the disc diffusion or Kirby-Bauer method, seen as shown here in the right part of the slide. Antimicrobial susceptibility testing will tell you which antimicrobial is susceptible, meaning it will inhibit bacterial growth. Intermediate, there is minimal inhibition, or resistant, or meaning it does not inhibit bacterial growth. Next slide, please. MDRO prevention and control. Preventing infections will reduce the burden of MDROs in healthcare setting, and prevention of antimicrobial resistance depends on appropriate clinical practices that should be incorporated into all routine patient care. This include the following: administrative support. These are your policy and procedures, staff education, judicious use of antimicrobials, MDRO surveillance. It's a critical, important component of any MDRO control program, allowing detection of newly emerging pathogens and measuring the effectiveness of interventions. As IPs in your facilities, it is important that you are aware of which residents who have MDROs, as not all MDROs are alike. It is important not to place residents with different type of infection in the same room. For example, a resident with an MRSM infection should not share a room with a resident who is infected or colonized with VRE. We do not want MDROs sharing their secrets with each other. Infection control precautions, utilizing contact precautions for MDRO infection, and enhanced barrier precautions is utilized for MDRO colonization. Enhanced barrier precautions are an infection control intervention designed to reduce transmission of resistant organisms during high contact resident care activities, and this type of precaution will be discussed in detail in session 5, prevention and control of communicable diseases, environmental measures such as your cleaning and disinfection, and lastly, your decolonization. Next slide, please. So question: a resident has a confirmed diagnosis of C. difficile. When cleaning and disinfecting an equipment, what is true with regards to the choice of cleaning or disinfecting a product? Is it A, B, C, or D? The answer is C. Because C. difficile is a more producing bacillus, it is important that a sporicidal cleaning or disinfecting product be used to ensure that spores are going to be killed. Next slide. Thank you. We have come to the end of the session. Thank you for your participation. If you have any questions or clarifications, please reach out to your hospital IPAC Hub lead. Good luck in writing the exam. Bye for now.
Great. So, Hannah, Victoria, Brigitte, excellent job. Really, really impressed with the delivery there. It's clear to me through this lecture that your passion for the residents in LTC and this content is very deep, and you clearly understand this. I think everybody who spent the last hour paying attention to the lecture is going to be 1 hour closer to successfully challenging the LTC CIP exam. I want to thank you both for your time, attention, and your expertise in this content area. So that was the third lecture in our series, Identification of Infectious Diseases. Thank you so much.